My talk today is specifically on telestroke. As Janine introduced me, I am working at the University of Kansas currently, KU School of Medicine, and this is my second year here, but I've also trained at Cincinnati and Rush in Chicago. I have no relevant disclosures. So I'd like to start with a little background. I think that telemedicine and telestroke is very important in a wider community, going into the rural communities. As you can see, only about 55% of Americans have access to a primary stroke center, a comprehensive stroke center within 60 minutes. And so about half of us do not live close enough to one of these centers where there are systems in place and there's experience in place to get treatment for stroke fast. And as you know, stroke is a very time-sensitive thing. Each minute lost is brain cells lost, and it's something that we want to treat as soon as we can and avoid any delays. Also, there are studies have shown that larger hospitals and those in more populated areas are more likely to give IV TPA, or also known as alteplase. And this is, at this point, the only FDA-approved medication to treat acute stroke and potentially reverse the stroke effects. There are other things like thrombectomy, which is an interventional procedure, but in terms of medication, you can give IV TPA is all we have at this point. There are some other newer drugs being tested, but at this point, all we have is IV TPA, and it has been shown to get a benefit in morbidity in 3 months. So there's been a study in Cincinnati, out of Cincinnati, from the years of 2005 to 2007, looking at the rates of TPA in all hospitals in the Midwest states. So as you can see here, all the red dots are dots that have TPA rate at the national average or above, and the yellow dots are those that have equal or greater to 10%. And so those are even a few that are even fewer. So you see that they're clustered around big cities. You have all of this West Kansas without the rates meeting the average or meeting 10%. And you get basically a lot of hospitals that are missed with getting the TPA rates up. So that's one study we've seen. Another one looked at the reasons or the hospital types, the predictors of hospital types that are less likely to give TPA. As you can see in the first few parts of that graph, bed size matters. So as the bed size increases, the rates of giving TPA go from all the way down to 0.3% to 2.6%. In terms of region, there's not too much of a difference everywhere. The only difference we see is in the South, a little bit lower. Northeast has the greatest. And then finally, the population density, as you get larger per square mile, per people per square mile, and you from less than 50 to over 500, the rates increase. Now, these are a little bit greater now. This was back in 2007, and so we do know that people are tending to give TPA more and more in the years since then. However, you do still see this trend in other studies where the larger hospitals, larger beds, larger population density, you get more TPA. So we really are trying to address this discrepancy and why there is this discrepancy between TPA and in different locations. And some theories we have are, first, a few theories that where we can't really do too much to change. One is the longer times to arrive at ED. People that come in from outside from the rural places to their community ED usually tend to have to drive a longer time. The ambulance has to drive a longer time, and so a lot of these people are getting missed by getting TPA in that acute time window. The maximum time you can give TPA in is in 4.5 hours, so that definitely affects it. 4.5 hours from when they were last normal. There has been discrepancy in community education identifying stroke, and we do know there's discrepancy between urban and rural centers. If you pull the community into signs that signs of recognizing stroke, as well as treatment options for stroke, as well as risk factors for stroke. So that relies more on community education. However, there are a few things that we can do on the hospital scale that may improve TPA rates. One is a lot of these rural hospitals only get 2 or maybe even 1 TPA case a year. And so if you don't see that many cases, you're not going to have staff that's experienced in the flow of things. You're not going to have protocols or systems in place that are smoothly flowing to the point where sometimes the times may get delayed and they may even fall out of the time window because of that. A couple other reasons is because you don't have stat radiology in the actual building, you don't have stat neurology in the building. You can maybe call them on the phone, but they may take some time showing up. And so that's also something in rural areas that are just part of it that we can help with. And so the question is mostly in how do we get this experience to the rural networks? How do we get this stat support, expertise, specialist support to these rural networks? And telestroke is definitely one of the ways we can do that, as well as telemedicine in general. So I'd like to just talk a little bit about what these hospital categories mean. So a PSC here is a primary stroke center. What that is they have to have certain capabilities, including a stroke director and ability to give TPA within adequate time, ability to get labs and imaging, and it's actually very strictly monitored by the Joints Commission. And the Comprehensive Stroke Center, CSC, are ones that where you have actual support that is on the interventional aspect. So you have interventional neuroradiologists as well as neurosurgeons, so they can do the more invasive procedures like a thrombectomy that you might get after you give somebody a TPA for an acute stroke. So there's this other part that where you do not have to be stroke certified, but this is an acute stroke ready hospital where you require some elements of the primary stroke center, including the protocols, a director, an ability to do these testing and give TPA 24/7. They often have additional support with regional primary and comprehensive stroke centers, and they're often transferred there after you give TPA. Here in Kansas, we actually have this distinction through the Kansas Initiative for Stroke Survival, or KISS, that is called Emergent Stroke Ready Hospital, similar to the Acute Stroke Ready Hospital that has been outlined as a directive by National Stroke literature. And this is regarding similar to acute stroke ready hospital, but specifically this is what they require: a written stroke protocol, written transfer agreement with the hospital with neurosurgical expertise, so that those patients who get the TPA or who may not get TPA but might still be a candidate for other interventions can get transferred quickly. You'll need a director. This could be either a physician or an administrator, and then obviously ability to 24/7 obtain things like brain image, like CT scans. CT angiograms would also be helpful, and that is an ability you can have coagulation tests and administer the thrombolytic or the TPA. And this is just a map from the KISS website in Kansas, where we have these hospitals. So the red ones are the ones that are the emergent stroke ready ones that have partnerships with us. Yellow ones are primary stroke centers. And then the blue, I think there might be one more by now, but the blue is the Comprehensive Stroke Center. There's also this other interventional capable hospitals. That's a totally different one that it's the halfway point between a primary and a comprehensive stroke center, which I won't go into, but this is just the map of where we see the partnerships with the hospitals in the area. So how this can be beneficial is because these partnerships, these hub and spoke networks, are very important to guide consultations, especially telestroke. So far, most people have telephone consults, and so I'll touch on that because I do want to make sure everybody's familiar with it. Most people do use this. KU, we have this BAT phone where there's a number right there they can use in case you want to directly talk to somebody. You can also get connected through the transfer center. The nurses there are trained to connect to a stroke physician right away. So basically within minutes, you'll be able to discuss the case, obtain recommendations. We can even help direct TPA treatment, go through exclusion, inclusion criteria with you, go through what you say to the patient's consent with you, and then arrange potential transfer. So telephone is definitely something we use all the time and has been very helpful, and is at the bare minimum something that we need to do, we need to continue doing. So then we go into telestroke, and the telestroke should be used to complement these telephone consults. I'll just briefly go over what the system looks like, what it is, and then tell you about the evidence we have and how it's beneficial. So this is just one company, Intouch, which we're using with one of our Hayes Regional Medical Center. And I'm not endorsing this particular company or over another. I've used Telegrid as well, but this is what their device looks like on the patient and Intouch's device. And this is just a little camera with a microphone and a speaker, and you see the physician's face, the stroke neurologist's face, and you even have a headset attached to it that you can call like a nurse or physician can pick up and talk to them directly instead of broadcasting the information everywhere. And so this is something that stays on all the time, and so as soon as we log in, we can get connected straight to this machine. And then on our end, this is what it looks like. So we get to see the patient's face, we get to see their body, we can zoom in, zoom out, we can turn up and down the microphone. They see our face, and we have a little picture of what they see on our screen. And we can turn a little bit, and then we even have cards, like stroke cards, with those pictures naming things, the diagram, and then the words and sentences they read out, so that they can see that on the screen as well. So we have all of that set up through the Telestroke network with Intouch. So this is a very important tool that we're going to use, try to use more and more frequently. I've used this a lot already, as well as another software. So this is just showing you what we have on our screen. So I guess the question is, does it work? So what evidence is there for telestroke in the first place? Why use it? So these are the earlier studies when telestroke first came out, looking at, is telestroke a good thing, is a good measure for these community hospitals that aren't experienced in stroke and don't have those expertise in-house. So the studies that we've seen so far have shown, and this is from a meta-analysis, that there's no difference at all between TPA directed via telestroke and then TPA given at the primary stroke centers in terms of whether it was appropriate to give, whether they have similar, whether other complications, and that is including a symptomatic ICH, which is the big complication we're afraid of, the bleed, as well as no difference in mortality or independence at 3 months. So it sounds like, based on this, telestroke is just as good as if you're physically there giving TPA. And one study actually did look at that. They did a telestroke with a team of neurologists versus an inpatient assessment by the same neurologist team, and they found that no matter how you give it, the method, there's no difference in complications and mortality. And so this is the difference between being there in person and having telestroke. So I guess, so that's all definitely something that we expect. That's good news. The next question is, how is it better than just telephone alone? So before I go into the evidence we have for this, I'll share my anecdotal experience I have. Especially from Cincinnati, where I did, I believe, over 100 telestroke consultations in just the year I was there. So for me, a telestroke over telephone, most of the cases I would get pretty much the same information either way, with the most common types of stroke, where you have weakness on one side, a facial droop on one side, an aphasia, and those are things that I think everybody is very, especially people who are in emergency rooms, are very trained to recognize, and even EMS is very trained to recognize. However, you have a lot of suspected stroke cases that are a little bit harder to tease out. So some strokes take place in the brainstem, in the back of the brain, or the posterior circulation. Those are the strokes that are definitely don't present like you expect. They can have things like dizziness and vertigo without anything else. And so those cases, it's hard to tease out sometimes if that's a stroke or if that's related to something in the inner ear or vestibular system. Also, you get much more severe strokes where you have patients with weakness on both sides. You have patients that are tired, lethargic, encephalopathic. In those cases, sometimes it's harder to tease out if it's a stroke or if it's something where they just are toxic or have some sort of lab abnormality or some sort of respiratory or cardiac abnormality. And so sometimes having the picture there when someone is suspecting a stroke but they're not sure is very useful when you don't, when it's not a typical anterior circulation MCA type stroke. Some of the other experiences I've had that have been helpful is when you're not sure if it's a stroke or something like a conversion disorder with psychogenic symptoms. Sometimes patients have little signs the neurologist can detect that indicate one over the other. There's also other stroke mimics like Bell's palsies and even seizures that sometimes the video can help. And then the final thing is many times you can tell it's a stroke, you can diagnose a stroke, but the symptoms are so mild that you're not sure if they're disabled. So disability means that it's actually a gray area. It's not always the same for every patient. We don't have a cutoff for NIH when we're giving TPA. The NIH stroke scale can be even as low as a 2 or a 1, and we would give TPA if they were disabled. So that is something that it might take a little bit more video information to determine this level of disability, especially if somebody has just some minor speech problems or some minor hand weakness or something like that. And we obviously don't want to give TPA to every single person who may have a stroke, because if you're not disabled and you do not have an actual dysfunction that's going to impede your life, then the risk of TPA in that case is not worth the benefit. And so there are definitely some situations where I've had the video be really helpful, and there's been some situations where I've discussed the case with somebody over telephone, and then suddenly I see them on the screen, and my decision for what I was planning on doing completely changes about giving TPA or not giving TPA. So now I want to talk about what the evidence shows about telestroke over telephone. And I'll show one study first. It's an earlier study from Northern Bavaria that used telestroke, which they called remote video examination versus telephone. This was not a true randomized controlled trial, but what they did was they rotated weekly. They did 1 week where they were using video, and the next week they were using telephone, and so on. And they did the study over a series of patients to see what the benefit was, what the difference was. And these are their results. They found they had about 77 that ended up being video, which is denoted by RVE. That first column, second column TC was the telephone. They found that, as you would expect, the total time was greater for the video over the telephone, 49 versus 27 minutes. They also found a significant more patients transferred to a primary stroke center with telephone than the video. I think that might denote that people, if you're not actually seeing the patient, you may not know if they're severe enough to need to transfer. So you might be transferring more patients into your center than you would otherwise. This would also be beneficial to have the video, because then you're not transferring patients unnecessarily. The big important things are in the bottom. The row that says diagnosis corrected, and this was basically looking at the final diagnosis, whether that was made which was whether the diagnosis was a stroke. That was correct, and that was if you look at the video over the telephone, they corrected it, meaning that the initial diagnosis was wrong only 7% of the time in the video, but 17% of the time in the telephone. So it looked like more than twice the number of patients had to change their diagnosis with the telephone than if you use the video about what the final diagnosis was, whether it was a stroke or not. And then finally, one thing that, and this is one of the studies that show this, but there is an increase, increase or decrease in mortality, in the video, 1.3% versus 6.8% 10 days after stroke. Now, this is pretty striking, and I'm not sure if most cases would be this different with the mortality, but this study did show that there was a difference in mortality if you use the video. I think a couple other studies that were done with a little bit more stringent data I'll go over now regarding telestroke is these 2 randomized control studies that were done to assess specifically decision making, whether the decision for telestroke for TPA was correct or not. And now these were a couple studies. These are through the stroke doc studies. There's one in Phoenix, one in San Diego, and they basically are a similar system that we have in KU, where there's a hub and then a bunch of spokes with more suburban and rural centers around it. So these were randomized controls, so the highest level of evidence. The outcomes they looked at were whether giving TPA was correct. And the next slide will show the way they decided whether it was correct or not. But it was mostly through blinded adjudication. And then they looked at a few secondary outcomes with TPA use rate, how many got TPA, complications, long-term functional outcome. So these are the ways they adjudicated. I'll go over that first, just to have your reference. And this is not as important except just to interpret the results graph I'm going to give you. Level 1 was just the hub, the main hospital consultant reviewed the case. Level 2A was an independent monitor, just a single person who reviewed all the records and made a decision. And level 2B, which is the higher level, that was the primary outcome that the studies used, was a committee with several people that are trained in acute stroke management, including neurologists, emergency room doctors. And so they came up with a consensus on, yes, this decision for TPA was correct or not. And that was blinded, so they didn't know whether that person got the TPA through telephone or telestroke in each case. So I'd like to go over the results. The first graph actually looks at time. They did find, similar to that Bavarian study, that if you use telestroke, the decision-making time was on average about 8 minutes longer than if you use telephone, which makes sense. So there's a lot of information on this graph and the source at the bottom if you want to look through this paper yourself. But I would like to draw your attention to the very last 2 parts where they looked at the telemedicine time to decision from the call was about 63 minutes, and the telephone time decision for the call was about 54 minutes. So as you can see, a little bit longer, that may cause some delays. And so this is a little drawback to the telestroke. And then later on, you also see a difference in consent to decision making in a similar way. The rest of the time intervals did not reach statistical significance except for mostly these 2 areas. And then here's the benefit that they found in the study. They found that using that level 2 adjudication, so the very best level of adjudication with the committee deciding whether it was right or wrong to give TPA in each situation, they found that for all patients, it was statistically significant, better correct decision-making with telestroke versus telephone. So that is really a big difference. It's, I believe, 96% versus 83%. So that's a big difference of patients that got TPA correctly. For patients and this is for all patients, so even the patients that didn't get TPA, they decided that, okay, they did not get TPA, and that was correct. They did not get TPA correctly. For patients, the bottom half of this graph just looks at the subgroup that got TPA, and there you do also see an improvement, 90% versus 79%. However, that one did not reach significance. So it seems to indicate that the telestroke really helped a little bit more in not giving TPA to patients inappropriately than giving TPA to patients appropriately. But the trend was there in both times, and then the correct decision making for all patients reached statistical significance. So that's very important. And this is one of the best evidence studies that compared telemedicine and telephone. So just to review the conclusion of the studies, and I'll tell you a little bit about the secondary outcomes as well. First of all, there was an improvement in decision-making for TPA in all patients when you look at did they get TPA and they should they have, and also did they not get TPA and they shouldn't have. So those seem like they were better, much better in all cases of telestroke over telephone. There was also increase in TPA use rate. Those first few studies I showed, first few slides I showed indicated that TPA rate in rural networks were very low. And you do see that 29 versus 24%, you do get TPA use with the telestroke over telephone, but this one did not reach statistical significance. It took 8 minutes longer on average, which I already talked about. And then the final thing, which we're all thinking about, is secondary outcomes. They did look at things like complications like bleeds resulting from TPA, as well as function and months, and they did not find a statistical significant difference, but they also noted that because of lack of kind of getting all those patients in follow-up, there was an underpowered, so the study didn't have enough people at the follow-up point to say for sure if there was going to be a statistical significant improvement in complications or not. So that's a very important landmark study that kind of made it into the neurostroke guidelines, which I'll show in a few slides, but I do want to go over a few other benefits of telestroke. A more recent meta-analysis in 2018 found that one of the benefits of telestroke was that there was a statistically significant decrease in the length of hospital stay for patients who got telestroke over telephone. And then finally, they also found all these studies have been very congruent in that they didn't find any increase in mortality with telestroke or complications of TPA with telestroke. So it's not like you're giving TPA too much to these people because you have them on video. You're actually giving TPA appropriately to these people. You're actually not giving TPA appropriately more often to people who may not actually need TPA than if you were just talking on the telephone and didn't get all the information, which is in line with my anecdotal experience. More times than not, I would talk to somebody on the phone. I would have an impression, okay, I'm going to give TPA to this person based on all I'm hearing. I'd see them on the video and I would say, no, this patient definitely should not get TPA. And so you're also saving a lot of people from that risk. And based on this data, it shows that it's a correct decision. So finally, I do want to touch a little bit on cost analysis. You know, obviously everyone's worried about whether this is a lot of investment for not that much benefit overall, especially if studies have shown not as much improvement in functional disability and mortality. So this study looked at a decision analytical model using all kinds of clinical financial data from this organ system before and after telestroke was implemented. So similar hub and spoke system like you had in San Diego, like you had in Phoenix, but it's Oregon. And they use this measure that's called the incremental cost effectiveness ratio, where they found that you get about 20,000 per quality adjusted life years to 71,000. And so, and this is not something that most people need to interpret or anything, but just so you know, the cutoff for whether something is appropriate for a quality adjusted life year ranges from 50,000 to 100,000 in literature. So it feels like this is in line with cost effectiveness based on what the boundary is in terms of quality adjusted life years. Again, and then they finally found out that telestroke, for more severe strokes, it was more cost effective than for milder strokes. As you can imagine, if you're saving more people and doing things more appropriately in a severe setting, you're doing a lot better in reducing costs overall. The costs reduced are on the line of nursing home admissions, rehab admissions, and just the cost it takes for somebody to recover from a more severe stroke versus recovering from a milder stroke. So I'd like to then go on to some of these guidelines. So these are the acute stroke guidelines from the Stroke Journal. So every 2 to 3 years, or actually 1 to 2 years, they come up with guidelines. They may update them, they may change them. And these guidelines range everything from systems like telestroke to just treatment for TPA, imaging, what you do after TPA, guidelines for blood pressure, guidelines for like antiplatelet medication, so for everything. And they did change a lot of these guidelines in 2018 based on those studies I mentioned, specifically the ones out of Phoenix and out of San Diego. So the first recommendation was because that there's limited neurosurgery, radiology expertise in places, using telemedicine telestroke systems can be beneficial and should be supported by systems, governments, payers, vendors. And then on top of that, even after that, you should be using this for correct IVTPA eligibility decision making, and also to direct. Number 5 there is all about directing TPA, administering TPA using the guidance of these telestroke physicians. And if you just read the paragraphs underneath, they just summarize those studies that I mentioned, the stroke doc studies, and then summarize like a systematic review, the other one I mentioned in the later slide. So this change did make it into the guidelines, and so that's important for people to be aware of. Whereas before, the guidelines were much softer. They were saying telestroke is a reasonable thing to do, and now they're saying, okay, well, they should be supported, and it can be affected not just as a general thing, but actually to guide IV alteplase, also known as TPA, administration through these networks. So I do want to make sure people know about the other strategies. I've touched a lot on telestroke, but everyone should be using telephone. If the telestroke is not available, continue using telephone. And that's also a decision that has remained there in the guidelines. Providing TPA decision-making support via telephone to community physicians is feasible and safe. And that's an alternative when you don't have an in-person stroke team or telestroke system. So keep using the phone, and they'll give you those numbers at the end. But like I said, the focus of this talk is that telestroke is now something that's also being recommended. This is not as much in the scope of this talk, but they actually do also make a strong recommendation for using teleradiology. So that's getting these CT scans, CTA scans, interpreting these CT scans, using out-of-house radiologists, and that's very important, especially in acute stroke settings. Many times we'll tell people to get a CT scan, but if they don't have somebody reading that CT scan, and I have no access to the CT scan, then that patient might be sitting there, and we won't know if they're a TPA case or not for however many minutes until somebody actually gets to read that CT scan. So if you don't have inpatient 24/7 radiology, especially neuroradiology, you have to use these teleradiology systems to review brain imaging and to help guide TPA decision making. That not only goes for CT, that goes for CT angiograms as well, because that's something that requires a little bit higher level of interpretation, and that can be important not necessarily for TPA, but to decide whether that patient needs to be transferred to higher level of care to get an intervention called the mechanical thrombectomy, where you put a catheter into the vessel and you basically use a retriever or an aspiration device to take the clot out where they're actually having the stroke. So that can only be done at these comprehensive stroke centers, and you want to get people out the door as fast as possible and get people to this level as fast as possible. So teleradiology is really important if you're going to read a CTA there, to go ahead and get that going. So I just want to briefly end on some other strategies for how to deal with strokes in rural locations, complementing telestroke. One is EMS prima notification. There was a large study on over 370,000 patients over 8 years that you see there, 2003, 2011, looking at EMS pre-notification, which happened in the majority of cases. It was associated with better door-to-imaging time and door-to-needle time. So you know that door-to-needle is a key to give TPA. We want to make sure everybody gets it within 60 minutes. So you see the times here a little bit faster, a little bit longer, but it was really important. It was really important in saving a little bit of time with door to imaging and door to needle. And the best place this will save is helping the patient go directly to the CT scanner. Other strategies in order to get people out and get people treated as fast as possible. You should have EMS staying nearby for suspecting an LVO, or otherwise known as a large vessel occlusion. And a lot of this is out of the scope of this talk, but large vessel occlusion is a clot in one of the major arteries where you can actually use that catheter to get the clot out using an interventional procedure. So the way you suspect that is because they have more severe deficits. And there's been a lot of talk about EMS looking through different pre-hospital screening tools and going through them and trying to figure out if someone may have an LVO. And if you do, then you have to arrange transfer right away. You have to make sure the patient goes directly to the CT scanner for all suspected stroke patients. If you are worried that they have larger deficits, consider getting a CTA with a CT angiogram of the head and neck with the CT, so that you're not wasting time for treatment and transfer. And studies have shown you don't have to wait for a creatinine to get a CT angiogram for stroke patients. So just go take them to the CTA. So in terms of telestroke, the way this would work is we would prefer to be notified as early as possible. Especially, so ED staff, when the patient's in a CT scanner and you're using telestroke, that would be a good time to notify, because it'll take a couple minutes for us to get our, we have a computer, and we also have an iPad with the telestroke system, but it'll take a couple minutes for us to make sure we're seated somewhere and then get it out and get it turned on and get it logged in. And so if the patient's using that time to get scanned, it'll save us time, and that way by the time we're logged on, the patient might be getting rolled back into the room, and we can go ahead and go and do the assessment. So don't wait until you get a read on the CT scan. Don't wait until you get neurology consult, in-house or a consultant. If you're using telestroke and you have an agreement with the stroke system, just call us right away. If it's not a stroke, if the CT shows a bleed, I mean, we're still happy to be notified early, and we'll just say, okay, definitely no TPA, and there's not too much more to do, but we can help you arrange transfer. But we'd rather know early and help out early, even if it ends up not being, even if it ends up that we're not needed, as opposed to finding out too late and wasting time. And then finally, and this is something that a lot of people do, but MRI brain is not needed, so don't wait for the patient to get an MRI. That takes at least 30 minutes to get, and oftentimes it's red. For suspecting a stroke, do not get an MRI. We treat strokes based on CTs, and we don't need an MRI to actually diagnose the stroke before we treat with any of these measures. So I'll end with a few resources. I'd like to direct you to the Kansas Initiative for Stroke Survival website, and if you're not already hooked in with us, and that was the map I showed you in the beginning, with all the sites around Kansas, those sites are hooked up with us. Director is Dr. Lechtenberg, who works out of KU, and so basically what we do is a lot of outreach, a lot of teaching sessions. We actually have a First Tuesdays lecture series where this morning I'm the one who gives a talk on that. I actually talked about telestroke in the past. We talked about looking at CT images, looking at CT perfusion images, deciding how to get people out the door, blood pressure management, and those lectures are all on the website. And so it's an important resource if you want more information. If you'd like to get hooked up through our telestroke system, or just have more questions on how to get an agreement with KU with your network, I direct you to Tony Nunn with his email address here, tnunn@kmc.edu. .edu, and he's our contact person for all the health technology systems set up. So if you have any questions, you can reach out to him on how to get hooked up. The transfer center phone is right there. You can call us anytime. If you tell the just tell the nurse who answers that I have an acute stroke, I need to speak to a neurologist urgently, and they know exactly what to do, and they'll transfer us, and we can, if we don't have telestroke, we can go through the telephone consult and talk through the case. If you have telestroke, obviously we can go ahead and get started. And then there's my contact information as well, in case you have some questions later down the line, or if you just have any sort of suggestions or anything you'd like to add. So with that, I will take some time for questions. I think that pretty much covers just a brief introduction on telestroke, what it is, the evidence behind it, the way it's been brought into the guidelines, and how we use it here at KU. So I'd like to take any questions now.
At this time, I don't see any questions in the chat or the Q&A folder. So if we want to take a few minutes and see if something comes through, we will.
Okay.
I do see a thank you from one of the participants. Janine, do you have any parting words?
You're welcome.
I do. I will share my screen. Well, thank you, Dr. Slavin. That was an excellent webinar, and I'm sure that others will come back to this again, as it is one that is recorded, and we'll be posting that on the AHEC site as well as the HTRC site in the near future. So thank you so much for that informative presentation.
Sure, and again, feel free to email me directly. I don't mind if you do want more information, or if you want to kind of get hooked up with us, you can also email Tony.
That's great. Thank you so much.
Yeah, no problem. Thank you.
All right, so our next webinar series is in January. Occurs the first Tuesday of every month, except in January, because that is actually New Year's Day. So we're going to go ahead and have that on Tuesday, January 8th. We're going to be talking about the implementation of Kansas Telemedicine Act and reimbursement. That presenter is, we're still identifying that, but definitely please tune in for that webinar as well, because I do know how reimbursement is incredibly important to everyone. So if you have questions about this Heartland Telehealth Resource Center webinar series, please do not hesitate to reach out and contact me at the information shown below. If you have ideas of what else you would like to hear about, we're looking even into next year about what other months that we can do and what topics those months will be in this webinar. So again, thank you for attending. And if you need more information, please contact us. Thank you so much. Have a great day and happy holidays.